Let me just see. Okay, good. Everyone, you can see that, Sean?
I can see that.
Okay, excellent. All right. Well, thank you for joining us today. I'm going to hand it over to Heather here for the first part of the talk.
Hey everyone, like Sean said, my name is Heather. I'm one of the nurses at the Adult Cystic Fibrosis Clinic at Vanderbilt. Thank you so much for joining us with our breakout session to discuss sexual and reproductive health post-introduction of modulator therapy. We feel like this is a really important topic to cover across the adult CF population. We've seen a lot of exciting and unexpected changes since the introduction of these therapies, specifically with Trikafta. Feel free to ask any questions at the end of the presentation. This will be recorded, so you can always go back and listen if you have anything you need to go back to later. All right, so changes in CF female patients that we're seeing post-modulator therapies. Women with CF generally have a thicker cervical mucus due to abnormal CFTR function. This thicker mucus actually makes it harder for sperm to successfully penetrate the cervix, and it increases the amount of time it takes for these women to become pregnant. However, since the introduction of modulator therapy, and most recently with Trikafta, there's been an increase in female CF patients becoming pregnant and maintaining healthy pregnancies. We've also seen improvement in the nutritional status post-introduction of modulator therapies. Prior to this change, poor nutrition could have contributed to fertility problems due to irregular ovulation, which is another reason that some women with CF may have had trouble conceiving. Birth control is a big topic that we've seen with reproductive health here since we've introduced Trikafta in 2019. There are a lot of different birth control methods. Some of those include intrauterine contraception, sterilization methods like vasectomies, tubal ligations. There are hormonal methods such as birth control, and then barrier methods such as condoms. So women with CF, whether you're on a modulator such as Trikafta or not, if you're not ready to have children, definitely be using contraception to help prevent the possibility of unplanned pregnancies. In our female CF patients that are not able to naturally conceive, but they still want biological children, assisted reproductive technology is an option. So these are things that include like IVF, IUI, and surrogacy. This is when we would refer you over to a fertility clinic and they walk you through all of these steps. So there's a ton of resources available on the CF Foundation that go into further detail on options for contraception and also with the assistive reproductive technologies. Dr. Tolle, you want to hit the next slide? Thank you. So for women with CF, becoming pregnant may bring along a lot of questions and changes that at one time weren't widely considered. So while fertility in women with CF has historically been mildly reduced due to the cervical mucus thickening, many women have struggled to conceive. So due to the introduction of Trikafta and other highly effective CFTR modulator therapies, the ability to conceive and maintain healthy pregnancies have become easier for many patients. Which leads us into our next discussion of questions that come up whenever we have had patients become pregnant. So once one of our female CF patients become pregnant, we recommend for them to be seen and followed their entire pregnancy by an OB that specializes in high-risk pregnancies. At Vanderbilt, this is typically with the maternal fetal medicine clinic. If a patient is considering becoming pregnant, we also recommend preconception planning meetings with the maternal fetal medicine clinic as well, if that's possible. We like for them to see these high-risk specialists just to receive closer monitoring and extra care throughout their pregnancy. For patients that live further away, having a local OB is very helpful, but most OBs and patients prefer to come to a hospital that has OB and anesthesia teams who are experienced with CF OB care for delivery. We get a lot of questions about Trikafta and other medications during pregnancy. At this time, data is actually being collected on Trikafta use during pregnancy. Later on, Dr. Tolle is going to talk more about this about the Mayflower study, which is researching taking Trikafta while pregnant with CF. While you are pregnant with CF, it is extremely important to discuss drug interactions and medication changes with your care team, as long as with your OB. For example, there are specific antibiotics and inhaled therapies that may need to be discontinued or changed while you're pregnant or breastfeeding. And we'll also go into more detail about this later. Genetic testing is another big topic. When our CF patients come to us with questions about wanting their partner's genetic tested while they are planning pregnancy, we usually direct them to their OB's practice, where their CF screening is usually offered as part of preconception planning. At this time, the OB may refer you to a genetic counselor where they can discuss in further detail about your results.
Unmute here. Okay. Thank you, Heather. I'm going to talk a little bit about fertility as with regards to men. So in terms of options for conceptions for men with CF, the vast majority of men who have typical cystic fibrosis, which would be CF diagnosed at a young age with sort of typical symptoms, about 97% the literature suggests are born without a vas deferens, which is the organ that connects the testicle where sperm are produced to the urethra where the sperm are released. And so even though sperm are made, they're not able to be released and to result in sort of natural conception. And that condition is called CBAVD, or congenital bilateral absence of the vas deferens. And so if that's the case, then those men would need to undergo assisted reproductive technologies to result in a pregnancy. Typically, what we would do here at Vanderbilt is refer a man who does not know his fertility status to a fertility clinic where they would perform a semen analysis that would confirm the absence of sperm. And if that is confirmed, then generally would refer the patient and partner to the fertility center to discuss IVF. In terms of what that specifically means for men with CF would be that because sperm are produced, they are stored in an organ called the epididymis, which sits sort of on top of the testicle inside the scrotum. And a urologist is able to go in with a needle and perform an epididymal aspiration to remove the sperm. And then those sperm can be used in vitro fertilization with eggs, which are obtained from the female, and then the fertilized eggs can be reimplanted. That generally takes a lot of planning, so we try to refer patients early if they're thinking about that, but it's certainly always an option. In Nashville, in the Middle Tennessee area, it's the National Fertility Center that we generally refer patients to, but there are fertility centers, obviously throughout the region. What about changes post-modulator for men? Well, unfortunately, at this point, there has not been much change. The vas deferens is created during early fetal development. So when the male is still developing in utero, that's when the vas deferens is formed. And so at this time, if you're already an adult and lack of vas deferens, taking the modulator does not affect that. And so there has not been much change with regards to male fertility in that respect. So generally with the lack of great data behind what to expect in pregnancy during cystic fibrosis, and especially the effects of modulators in pregnancy, there's been a study which has been proposed and is now just recently started, called the Mayflower study, which is the maternal and fetal outcomes in the era of modulators. And the reason this study is being done, it's partly to see what the effect of modulators are with pregnancy, a question that we'll talk a little bit about that I think is on everyone's mind, but also really getting systematic data on the effects of pregnancy and cystic fibrosis. Thinking back, especially before the era of highly effective modulator therapy, pregnancy and the decision to become pregnant as a woman with CF is a major decision because it can have major impacts on your health. Traditionally, sort of the materials that have been prepared and sort of disseminated to CF centers, typically suggests that a woman should have pretty good lung function defined as an FEV1 of greater than 50% of predicted to help have some reserve for times of when you're pregnant and you have increased dyspnea or a tendency to have exacerbations, that there's some reserve there, and that nutritional status be optimized. And obviously that it's a very difficult thing to go through. And so there was always a lot of thought given to the safety of pregnancy. Now in the era of modulator therapy, with on average patients taking modulators having improved lung function, improved nutritional status, there's less sort of barrier and concern there. But at the same time, it's, as Heather spoke about, fertility has been enhanced quite a bit, and it's been evident that it's much easier to get pregnant. And so the question then is, what to do with modulator therapy in that setting. And so we looked, we've obviously done studies on CFTR modulators for about 10 years. Ivacaftor was released in about 2012, and Trikafta obviously almost 3 years ago. And unfortunately, those studies give us no data because pregnant women were excluded from those studies by design. And if you became pregnant during the study, you had to stop the drug and leave the study. And that's because the ethics of giving a pregnant woman and a developing fetus a drug that has unclear safety really is not considered appropriate. And so there really is no data. And the manufacturers generally in their FDA labels, counsel against taking it during pregnancy because of this lack of data, and to discuss with your healthcare team. The real world experience early on was that there was a lot of concern. And so some women continued Trikafta and some women wanted to stop it, or before Trikafta, obviously Ivacaftor and patients who were eligible for it. I'd say that many or most of those patients, felt a lot worse coming off the modulator therapy, and I'd say most resumed it. And now, over the last couple of years, there's been such an experience, and there's a lot within the community and on social media of women sharing their experiences that I would say now it's incredibly rare for someone to stop Trikafta during pregnancy, but it's all being done without any great data on what to expect from that. There have been no clear signs of any problems at all. And we think probably in general, it's much better to stay on it because the healthier you are when you're pregnant, the better it is for you and for your baby. But the hope with the Mayflower study is to actually get some of this data and really know and have it be, one of the better studied drugs during pregnancy, because a lot of drugs don't have great data during pregnancy because it's all sort of after the fact discovery of effects. So in terms of Mayflower study, it's a prospective multi-center observational study, which means that it's designed in advance. It's being done at multiple centers. We are a center here. We have now started enrolling patients, and it's observational, meaning patients are just going about their lives and we're recording data, but we're not doing any interventions. You don't have to be on a modulator to be in this study. Patients who are on modulator or not on modulator are eligible. It's designed to go 35 months. You're intended to be enrolled in the first trimester and then continue for 2 years after delivery. The primary endpoint, meaning the main thing being looked at, is changes in lung function over that time. But there are several secondary endpoints, including evaluating pregnancy-related complications, obstetrical complications, just changes that it might lead to just with the pregnancy itself, and then changes in mental health. And like I said, the study has just started, so we have no data yet from this. What about medications in pregnancy? Heather mentioned that there are several things we think about changing. And just sort of to go through these, most of the inhaled regimen, the vast majority is good to continue on. Doesn't have any significant harm to fetus at all. So that includes pulmozyme, hypertonic saline, the bronchodilators like albuterol, the combination inhaled steroid inhalers that we use in cystic fibrosis and in asthma. Are all generally safe to use. And in general, the benefits we feel like would outweigh any sort of theoretical risk that some of these drugs have assigned to them. Because generally we want your health to be optimized and to be as good as possible during pregnancy. And so stopping a therapy that might lead to a decline in your health is worse. Antibiotics require a little more consideration because there are some antibiotics that definitely cause birth defects or other problems in babies. The big one in terms of maintenance therapies is the inhaled topramycin. So tobramycin in that class of drugs is generally avoided during pregnancy, if at all possible. And so we usually stop inhaled tobramycin. For antibiotics during exacerbations, there definitely are some we do not use. The tetracycline class, which includes the doxycycline that we use fairly frequently for MRSA, is contraindicated generally in pregnancy. We tend to avoid Bactrim. And then the quinolones, which includes ciprofloxacin and levofloxacin, which are our main oral antibiotics for Pseudomonas, and which a lot of patients take when they have a flare. They're not absolutely contraindicated. There's some concern they can affect cartilage development and affect the baby's joints. And there are, it's felt that it can be appropriate to use at certain timing and certain sort of cases. We generally avoid it though, because we don't want to do any harm. Most of the intravenous antibiotics that are used for Pseudomonas and staph are okay. So vancomycin and most of the IV drugs like Zosyn and cefepime are considered safe during pregnancy. But tobramycin, for instance, we would never use. So there's a lot of consideration with antibiotics. Modulators we spoke a little bit about. It is a huge unknown. We're hoping the Mayflower study answers that, but so far I'd say the consensus in the community and in the medical end of the community is that the benefits we think at this time seem to outweigh the risks, but we don't have a great knowledge of that. We're hoping that these studies will help us. Drug interactions and other therapies. So there definitely can be some drug interactions and some issues with dosing of antibiotics that come up with pregnancy. So I want to thank everyone for being with us during this talk, and certainly would like to open up any questions that anyone has.